We're going to start, and Megan is going to start with the clinical history of this exciting case. Megan?
This was a case at UW in the fall of a 47-year-old man who came in with AML after a peripheral blood stem cell transplant. He actually presented at day 42 after he had the transplant for AML. It was his second transplant. His initial was in 2016. For this transplant, he was conditioned with fludarabine, treosulfan, and this other thing for this study protocol. And then he had been on MMF and cyclosporin post-transplant. His course had already been complicated by CMV viremia, which he had on day 7 after the transplant. Initially was treated with foscarnet, which was briefly changed again cyclovir. That change is unclear why it happened. Then was resumed on foscarnet in the setting of a worsening CMV level. Unfortunately, he developed an AKI, so they switched him back to ganciclovir 2 days before he presented to the hospital. And he actually initially presented with painful and frequent urination with minimal output each time. He also had a penile ulcer, hematuria, and in the setting of the pain had pretty severe nausea. And it was noted that he had a pruritic rash on his chest and upper arms as well. Just some social history, because he was a really delightful patient to take care of. He was originally born in Kenya. He moved to the US in 2017, but had worked as a fitness instructor on a cruise ships for many years and traveled all over the world. And he was working as a rideshare driver. He actually had 18 siblings, so he had multiple options for his stem cell transplants. So the initial workup that was done to see about his dysuria as well as the rash, he had an HSV swab of the penile ulcer, which was negative. He also had a negative adenovirus in the urine. He did have quite a high BK urine quant and a serum quant as well, and was started on, actually he wasn't started on it in the end. Yeah. And then he had a UA that had 3+ protein and 3+ blood. Interestingly, he had had one just prior to admission, which was completely negative. And then he had a UPCR, which was 16. The repeat was 6.6. And the albumin creatinine ratio was 8 with that original urine protein creatinine ratio. He had a uric acid, which was negative, C3 normal, C4 of 69, SPEP was normal. And he had fully placed pretty early on because he had such severe dysuria with a penile ulcer. Nephrology was actually not consulted until day 5, I believe, of his hospitalization. He initially came in with a slight AKI with creatinine of 1.4 from his baseline of 0.6 to 0.8, which was thought to be due to his foscarnet. And it improved after switching to ganciclovir, but then started rising again. So on hospital day 5, the creatinine was 1.4 again, as well as new hyperkalemia. And so nephrology was consulted at that point, and he ended up undergoing a biopsy on hospital day 8 when his creatinine was at its peak of 1.8.
Okay, pretty complicated history that this patient has. Questions for Megan, and in the meanwhile, you can start putting your check marks in front of the differential diagnosis that the clinical team had at that time. And tell me if you agree or not. Okay, I have a question for Megan. Megan, so was BK also detected in the blood?
Yes, it
It was
was.
only in the urine. Yes?
Mm-hmm.
And do we know what was the titer copy numbers?
The serum quant in the blood was originally 50.
Okay, thank you. Okay, pretty much we have everything. The most I can see that most people put drug-related foscarnet and CNI, BK cystitis, GVHD. Nobody liked ulcer from CMV. Minimal change, membranous nephropathy. Pretty good. Yeah. Okay, fantastic. Now, let's see that what we saw in the biopsy. Anybody else has any questions for Megan at this point? Okay, so let's move on. So, all right, okay, thank you. So this is low magnification of the biopsy, so pretty good biopsy size. That's what we like, 26 to 28 glomeruli. It was all cortex, though. I mean, as you know, I mean, we always love to have cortex and enough cortex as well. For some diagnoses, however, I have to say, I mean, we talked about BK. You realize that, sometimes having a piece of medulla is not bad, and that could be more sensitive for some of the diagnoses, such as polymovirus nephropathy. Okay, putting that aside, very nice biopsy from cortex with 26 to 28 glomeruli per level section. Only one was globally sclerosed. As you can tell, this is Jones methylamine silver, so we're seeing the basal membranes is black, and the darker areas in the interstitium, such as in these areas that I'm showing, are representing chronic injury. So as you can guess from this low magnification, actually, there was not much chronic injury. You have renal capsule on one end and a little bit of chronic injury, maybe here and there. Very mild chronic injury. Okay, we can't tell much from about the glomeruli at this magnification. And for the tubules, I mean, they are not that remarkable. Maybe in some areas, I can see that they're a little bit maybe dilated or have more white space in the middle. So indeed, in some of or most of the fields of this biopsy, when we were looking at the tubular interstitium, we were seeing that tubules, they're back to back, so the interstitium was not expanded, and the tubules did not look particularly bad. However, in some other areas, we had these patchy areas that they didn't look quite as nice as the first slide that I showed. So what is the main abnormality in this figure that you can detect? Thrombotic microangiopathy, acute tubular injury, tubular interstitial nephritis, or glomerulonephritis. So I see that, yeah, the check marks are growing on acute tubular injury, and that is indeed correct. I do not see any like thrombi, any obvious thrombi in the vessels or in the glomeruli for thrombotic microangiopathy. And rather, in the tubule, in this higher magnification, you can see that better, we see some changes. So typically, the normal proximal tubules, we see brush borders. In these ones, as you can see, the brush borders are pretty much sloughed off, and the tubular epithelial cells are becoming cuboidal. And there were indeed some that were quite flattened as well. So yes, there was acute tubular injury, and everyone was correct about that. This is another view from another area of this biopsy, and as you can see, we see more changes. So looking at this tubule, we see that there are these sloughed tubular epithelial cells, or rather pieces of tubular epithelial cells in those that we do not see nuclei. That's one of the features of acute tubular injury. And some of these tubules are actually have pretty flat epithelial cells, and the nuclei are just bulging out. And some of them, more similar to the one that I showed you, have lost brush borders. It is not uncommon in acute tubular injury to also see some interstitial edema, similar to what we are seeing in this biopsy. So there was focal interstitial edema with scattered inflammatory cells. Not many inflammatory cells, there were just few, and that is pretty common reaction to acute tubular injury. But as you can notice in some of those tubules at lower magnification, and also you see that more prominently in this view, looking at these tubules, one wonders that if there is something else also is going on. So the question is that, what do you see in this figure? Renal cell carcinoma, viral inclusions in tubules, reactive changes in tubular epithelial cells. And when we say reactive changes, we mean reactive to injury of acute tubular injury. B or C, and we need additional studies. Okay, so I see that there are more check marks on D, and then also there are some on B and some on C. And in fact, I would say that is correct, that we cannot be quite sure in most of these instances, especially given the history that Megan provided, that, okay, yes, there is acute tubular injury, but there are so many causes for acute tubular injury. Besides, this patient has, of course, risk factors for developing polymovirus. And looking at these, what you see is that the nuclei are enlarged, right? And they have very prominent nucleoli. And those are features that we see in basically reactive changes to acute tubular injury. However, in some of them, one wonders, are there some inclusions? And these nuclei, they look large, they look enlarged. And sometimes it's not that easy to pick up the inclusions. So I agree with D, so that we need to do additional studies. So what kind of additional studies? I assume that those who answer D, they know and they expect to see SV40 large T antigen staining. So this is stain that basically as I said, the stains for SV40 large T antigen. It's a nuclear stain. This is an example. This is not from this biopsy. This is from another biopsy. Very strong, that shows very strong nuclear staining in those nuclei that express SV40, which, the most common one and the main question in this biopsy would be polymovirus. In this biopsy, however, we did not identify positive nuclei. Would that 100% rule out presence of polymovirus nephropathy? As I said, you have to consider that also we would like to, it can be a patchy process, and especially for polymovirus, sometimes you see positivity in medulla and you don't see positivity in the cortex. So not 100%, but nevertheless, it was a very good sample and we did not see any positive. Okay, so we put that aside. There are other changes as well, very focally, however. So very focally, we also show these lesions. Okay, so the arrows show normal tubules, viral inclusions in the tubules, acute tubular injury, tubulitis. We can put more than one check mark if you like. Tubulitis, and that is correct. And that is correct. Although, I mean, again, going back to the question, one may ask, okay, I'm seeing that's part of the chromatin here in this enlarged nucleus, looks paler. Is this an inclusion or not? But we already addressed that concern with SV40 large T antigen. So look at here. I mean, these are tubules, and exactly these dark chromatin, smaller nuclei that are inside, they are lymphocytes, and this is showing tubulitis. And that was present in some other areas as well. So we had very mild tubulitis, but nevertheless, it was not that prominent. It is not very uncommon to see rare, occasional scattered tubulitis as a response to a reactive response to acute tubular injury either. Okay, so looking at the vessels, so this is an interlobular artery, as you can see, this is the lumen, and this is the media. And the vessels were all unremarkable. We did not see any thrombotic microangiopathy. How about the glomeruli? If you want to make a comment about these beautiful glomerulus, how do you call it? Unremarkable. It's a membranous nephropathy, FSGS TMA. Remember that this patient had, nephrotic range proteinuria. So what would you say? I mean, just how does it look like? Unremarkable. Everyone agrees? Beautiful. Okay, I agree with that one. Yes, yeah. So it looks beautiful and it looks unremarkable to me as well. So by light microscopy, does it rule out that there is no membranous nephropathy? Of course, you need to wait until we see immunofluorescence and electron microscopy for that. Just another picture of this, or another rather beautiful glomerulus from this biopsy by H&E stain, and it was really unremarkable. No thrombotic microangiopathy, no obvious membranous nephropathy by light microscopy, which appears as thickening of the glomerular base membrane and spikes, no FSGS in over 25 glomeruli. So really Probably that was a reliable statement that the glomeruli were unremarkable by light microscopy. Now let's look at immunofluorescence, because in early membranous nephropathy, of course, you can see unremarkable glomeruli by light. So now let's look at this picture. This is IgG stain. And in order to make it a little bit easier, so this is the glomerulus with that circle around it. So there was no glomerular stain. But you see, indeed, positive staining outside of the glomerulus. So there is some positivity here. So the question is that what structure is showing the staining here? TBM, peritubular capillary, Bowman's capsule, or an arterial, if it's not a glomerulus. Okay, TBM, PTC, Bowman's capsule. All right, and there are more votes on TBM, and I like that. Indeed, these are tubular basal membranes. So if you can see, I hope if your screen allows, this is a peritubular capillary. You may be able to see that, or this is a peritubular capillary, and they are not showing staining. Around it is interstitium, and these are tubules. So yes, there is indeed granular tubular basal membrane staining for IgG, and that was only for IgG, kappa, and lambda, and a little bit for C3. We did not have any staining for the other immune reactants. Okay, so now let's move to electron microscopy. Of course, I mean, with that negative immunofluorescence finding in the glomeruli, the likelihood to see immune complexes by electron microscopy is also pretty low. But remember that this patient had nephrotic range proteinuria. And by immunofluorescence, I guess that you did not favor that it was membranous nephropathy, because there was no positive staining in the glomeruli. So what is the other differential? In that list that Megan showed, and some of you also put check mark in front of it, there was minimal change disease. So here is my question. How do you describe podocyte food process effacement in this picture? Extensive effacement or mostly intact? Okay, I see growing votes on mostly intact, and that is correct. So, showing you these are capillary lumina. In the middle, we have the mesangium. This is the glomerular basal membrane. And outside of it, we have podocyte. So these are podocyte, and these are food processes. And as you can see, in many areas that we are looking at, indeed, pretty much there is none, or there is very little effacement or widening of food processes. In many of these instances, we can see food processes nicely. And that was not only that region. This is another capillary loop. And again, you see that these food processes are pretty much intact or close to intact. There were no immune type deposits in the glomeruli. Again, another view just to convince you that really that was a true observation, that there were many of these food processes, I mean, the great majority of them, they were intact and they were not effaced. Okay, so that perplexes things maybe a little bit. We'll talk about that too, how we should interpret that. Nephrotic range proteinuria, it's not membranous nephropathy, it's not TMA, and the findings are not compatible with minimal change disease. Now let's look at this picture, and I made it a little bit easier for you by putting a label here that actually what you're looking at is proximal tubule, and these are the beautiful brush borders in the middle at the apical side of these proximal tubules, proximal tubular epitheliosis, as you can see, and at the bottom, at the base, you see basolateral infoldings, and of course, at the base, you see the tubular basal membrane, right? Okay. And when you look at these tubular basal membranes, we have what these arrows are showing. Deposits, discrete deposits. So tubular basal membrane deposits that correlate with what we saw by immunofluorescence microscopy. Again, here, at a higher magnification, you can tell that this is a proximal tubule because it's very rich in basolateral infoldings and had has numerous mitochondria in the cytoplasm, tubular basal membrane, and tubular basal membrane deposits. So we have so many tubular basal membrane deposits. Okay. So tubular basal membrane deposits, we confirmed that by immunofluorescence, we confirmed that by electron microscopy. Here it comes the question for you. Which of the following is associated with presence of tubular basal membrane deposits? Lupus nephritis, polyomavirus nephropathy, IgG4 related renal disease, hematopoietic stem cell transplantation, this case, Sjogren, idiopathic hypocomplementemic tubulointerstitial nephritis, anti-LRP2. Okay, yeah, very nice. Keep putting your check marks. So lupus nephritis, it's very common to have tubular basal membrane deposits. Absolutely, that is the correct answer. Polyomavirus nephropathy, that is also correct. And that was one of the concerns when we saw the immunofluorescence microscopy that, oh my God, and at that time we didn't have SV40. That maybe it's BK because I mean, everything else in the history was also pointing to BK. And that is correct. So, but mostly in cases that we have extensive polyomavirus infection in the kidney. IgG4 related renal disease, of course, we have tubular basal membrane deposits. That's pretty common. Hematopoietic stem cell transplantation. It is not a common, but I would put a check mark there, and I will show you. And this is rather like another case that can be reported with that, I guess. Sjogren's syndrome, yes, it can be associated with that. Idiopathic hypercomplementary nephritis, numerous deposits you see in TBM and in the interstitium. And anti-LRP2 nephropathy, of course, you can see tubular basal membrane deposit. There are others. The list is rather longer than this. Okay, thank you. So this was the final diagnosis that we made based on the findings. So acute tubular injury, an IgG tubular basal membrane deposits by immunofluorescence and electron microscopy. Remember, these IgG deposits, they were polytypic. I said that they were positive for IgG, C3, kappa, and lambda light chains. Okay, so we had acute tubular injury with relatively mild histologic severity. Probably the reason, the culprit for AKI that was discovered. As I showed you, the tubulitis was really focal, and you had to look hard to find those instances that I showed to you. So it's unlikely to be able to call it tubular nephritis. We had focal deposition of polytypic IgG in the tubular basal membrane. So here we talk about, okay, yes, SV40 definitely is in the differential and concern, but I mean polyomavirus, but SV40 was negative, and we didn't find like diagnostic viral cytopathic changes either, so we don't think that that was the case. And but we talk about GVHD, we talk about other possibilities as well. Now we get into the nephrotic range proteinuria with almost no or very little food process replacements. Could that occur or not? So, in fact, not all studies are indicative that there is a like a one-to-one correlation, especially in conditions where the patient is receiving immunosuppression and prednisone. So, I'm not aware of directly a case similar to ours in terms of, okay, hematopoietic stem cell transplantation and nephrotic range proteinuria and no food process replacement and those things. But maybe something closer to this condition is this paper by Vandenberg that basically they measured food process width in different conditions, including minimal change nephrotic syndrome. And so this minimal change nephrotic syndrome, prednisone, that means the patient is in relapse on prednisone. And this is minimal change in remission that is very close and not different from the control. But look at here. I mean, the ones that they go on relapse and on prednisone, they are closer to the controls. And when you look at here, this scatter plot, the circles, the empty circles, the white circles are the ones that are relapsing and on our prednisone, minimal changes. So you see that we can have cases that their food processes is within the normal range or close to the average of what they observed in the normal range, but still the patient has more than 3 or 4 gram proteinuria per day. So we thought that that might be the case. And here I'm also showing you the beautiful article that our own Dr. Ingrani Sangita wrote a few years ago in New England, and describing that basic different mechanisms that can lead to kidney complication in patients receiving hematopoietic stem cell transplantation. And many of those things that we talked about here can be seen. So acute GVHD, chronic GVHD leading to endothelial injury, leading to TMA or acute tubular injury. Podocyte injury can be seen. Membranous nephropathy that is believed to be related to chronic GVHD, or minimal change. So minimal change could be due to different things. Actually, a question for Megan comes up here: if this patient had received any vaccine recently, because some of the reports are related to vaccines in these patients. Some of them are related to like stopping or tapering of calcineurin inhibitor, or some of them right prior to GVHD manifestations. Any vaccination, Megan?
I don't remember any vaccinations, and I would guess that any of them had happened before his stem cell transplant, and he was 47 days out. So I don't know about the timing you see, but it seems like it'd be pretty delayed if he had vaccinations before the transplant.
Okay, thank you. Any change in the medications like cyclosporine or?
No,
No.
he'd been on the cyclosporin. The dose may have changed when they had the concern for GVHD. I'd have to look back and see, but it hadn't been tapered, and it hadn't been stopped for any reason.
Okay, thank you. And this is a case report that actually, relatively recently in 2023 was published. And in this case, so there are, when you look at the complications, of course, they're all over the place. In some reports, acute tubular injury is the most common. We have TMA is another common. Immune complex glomerulonephritis, membranous nephropathy is the most common. Minimal change disease has been reported. When we say minimal change disease, remember that, besides nephrotic syndrome and no immune complexes, we also need to see extensive food process effacement. So they have been reported. But these isolated tubular basal membrane deposits, it's very rare. So this paper in 2023 claimed that it's the first report. So our case maybe is the second. That case did not have significant proteinuria like ours, and our case was more complicated because besides the significant proteinuria, the food processes were normal. Tubular basal membrane deposits in association with membranous nephropathy or immune complexes in the glomeruli have been reported in hematopoietic stem cell transplant. So those things exist, but this likely, and based on what Megan was saying, we probably can't attribute that event of nephrotic syndrome to vaccinations or tapering of the drugs and things either. So our hypothesis is that this is probably basically a manifestation of, similar to what I showed you, similar to minimal change disease on immunosuppression. There is no good correlation between food process with proteinuria in such cases. Okay, now, if you have questions for me for the pathology, please bring it up. And Megan has some interesting follow-up about this patient as well.
Yeah, so Ashley commented, which was the thought, that his gross hematuria when he had the original urine protein creatinine ratio of 16 on repeat 6 was maybe a contamination from the blood. He had bladder irrigation, which greatly improved his hemorrhagic cystitis. And on repeat, his urine protein creatinine ratio was down to 0.6. And I just noticed it was repeated very recently and it was down to 0.1.
Okay.
Essentially, so I actually started caring for him after his biopsy, and his creatinine was back to normal by hospital day 13. We got the original biopsy results that showed the tubular injury, and the SV40 stain was still pending. So at that time, he was also being treated for GVHD, which they thought was the cause of the rash, and actually also his GI symptoms. So we were wondering, are we still looking at BK nephropathy? But he's also being treated for GVHD, so the idea of going either up or down on his immunosuppression didn't feel quite comfortable yet without a clear cause. And his creatinine returned to normal without any intervention and stayed normal through the rest of the hospitalization. His BK urine quant came down dramatically, as well as his serum quant without any changes in that. And the cyclosporin was being guided by the hemonc team, which they were doing for his GVHD per their prophylaxis protocol. So we actually didn't make any changes after the biopsy. When the SV40 stain came back negative, that was sort of when we officially decided to not make any changes based on the biopsy. And then I think he actually followed up with Ashley in clinic. So I didn't know if he had other thoughts of why he had this tubular injury. The initial thought when he came in was that he had an AKI due to his foscarnet. But interestingly, when he was switched to ganciclovir, that AKI actually did resolve back to a creatinine of normal. And then there seemed to be a new AKI, which started a few days later. I didn't see him when he came in, so I don't know how severe his nausea was, if he really wasn't able to eat or drink anything, and if that maybe caused some acute tubular injury. So I don't have a great explanation for the actual tubular injury part of it. And then the nephropathy part of it was thought to be most probably contamination, given that it resolved. And like you were saying, with the foot processes being normal on biopsy.
So I have a question for you and Ashley again. So you showed us that also albumin creatinine ratio was 8 gram per gram.
Mm-hmm.
So could that also be related to contamination?
I don't know the answer to that. I feel like not. But we didn't make any changes, and his repeat, I believe that repeat was during the hospitalization after pretty intensive bladder irrigation and resolution of the hemorrhagic cystitis. So I don't know where the albumin would be coming from, or if that would be contamination from blood as well.
Just a quick comment on that. So, if you think about how much protein's in blood, there's kind of 4 grams per deciliter of albumin, 7 grams per deciliter or thereabouts of total protein. And the creatinine in the blood is about 1 milligram per deciliter. So if you just took a protein creatinine ratio of blood, if my very quick math is right, it would be about like 7,000. So you can get elevated urine albumin creatinine ratio and protein creatinine ratio. It just depends how much contamination there is for the blood. Obviously, we don't see that just with microscopic hematuria.
Okay, thank you for the comment, Ashley. Any questions?
I think you've addressed most of the questions in the chat. Nikolai did ask about staining for crystals, and Suzanne was wondering about whether maybe in theory the lack of foot process effacement could be related to sampling.
So for the crystals, we don't by staining for crystals. I don't know about birefringent crystals. There were no crystals. I don't remember if we did polarize or not, but there was nothing to raise concern for crystals morphologically. And also about the sampling, at least I can tell you that in all glomerular images that we looked, actually foot processes, they were fine, or very limited widening.
Was that there reports of AKI and severe glomerular injury with crystals from foscarnet? So I think that should be part of the evaluation.
Could you say that again? I couldn't quite hear.
I was looking up, and there are reports for patients with AIDS, or patients after transplants, or patients after bone marrow transplants, where phosphocarnet can cause this crystallization in the
course,
tubules,
yes.
as well as in the glomeruli, and cause severe glomerular basement injury that can be very patchy and potentially a sampling issue here. So that's why I was asking about the birefringent crystals. I think that
No,
should be the evaluation for this case.
Yeah, absolutely. No, I can take another look, but I mean, it was there was really nothing to suggest that we have crystals, including phosphocarnet crystals, and it was a pretty good sample.
This is Bilal. Just one quick comment. If
Yeah.
the immune-mediated issues with GVHD, they take a long time to resolve. So this is too fast of a resolution, in my assessment, to be related to any GVHD on the renal, tissue.
Good point. Any other questions, comments? Okay. So if there are no questions, it's time to move on to the second case that Anand will be presenting. Let me stop sharing. Anand, we can't hear
You're
you.
muted.
Yeah, I don't see that you're muted, but
Does that one work? Okay. I see. Can you hear me now?
yes, yeah.
Okay, so I'm gonna start getting set up. Manny, do you need to share
Yes.
your
Your voice is a little bit low. Is there any way that you can increase the volume of your microphone in the setting?
I think it's max, but let me try just putting this closer and talking louder. Did that work?
Thank you.
And sorry, Manny, I was saying, do you want to share your screen, or I have a placeholder slide I can.
Yeah, I was saying that I don't have slides, but I prepped the presentation, so just let me know when.
Okay, great. 1 second, let me start sharing, and then is that looking right now?
That looks good.
Okay. So yeah.
Yeah, I'll take it from here. So this is a 50-year-old female with a concern for progressive CKD. We were consulted for a non-oliguric AKI. She has history of aplastic anemia, status post stem cell transplant that was back in February 2022. And then eventually developed graft versus host disease with TMA in June of 2023. And that was from an upper GI sample. And then she was admitted here due to worsening hypoxia at home and saturations down to the 60s. Bit of her history, her baseline creatinine, it's about 1. And then she started having a slow rise in creatinine since July. On presentation, her creatinine is 3.4. For her BMP, just bear with me here. Her sodium is 141, which is within limits. Her K, 4.1. Chloride, 109. Barcar is a bit low at 20, or like a borderline 23. A BUN, 43. And then the creatinine, 3.42. Calcium, 8.8. MAC at limit 2, and then phos 4.6. Her CBC show anemia at 8.5, white count 7.4, and then low platelets at 108. She had elevated LDH, and low haptoglobin as well. In the urine, it was positive for proteinuria, RBCs, and white cells. We spun her urine and we show granular debris, and then some concern for ATI there. We also collected complements, RF, ANA, ANCA, SPEP, UPEP, free light chain. All of that was within limits. Her UPCR was 1.9 grams, UACR in the 700s milligrams. Her serum albumin 3.6. Eventually, she underwent biopsy on the 8th, like 4 days after admission, and I'll let you know what happened afterwards.
You. So I don't have the multiple choice options, but you can try doing the text to annotate if you want to give me your differential, and in the meanwhile, if anyone has questions for Manny about the history, you can do that as well.
Any thoughts at the moment?
Otherwise, we won't belabor this. It's a similar differential from before, I think, in the following a stem cell transplant.
How long was it?
Can you say that again?
I don't know if I heard that. I thought I heard what, like how.
I cannot hear you well.
Like, is that in
Yeah, her proteinuria was 1.9 grams, and then albuminuria was in the 780 milligrams. Just non-nephrotic range. And then again, she had low hapto, LDH elevated, low platelets, anemia as well.
Did she have any prior measurements of her urine protein?
No prior one so far. But yes, I see one thought of a TMA. Anything else? I was concerned about ATI as well, based on the urine microscopy. As I mentioned before, she had graft versus host disease 2 in the past with TMA. That was back in June 2023. So maybe some of that could be infection, or any, maybe even some drug related as well. So those are some of the thoughts. No concern for post-renal or pre-renal at this moment.
Okay. Is that audio any better?
A lot better.
Okay, great. My cable was loose. Sorry about that. Hopefully that stays stable. Okay, so thank you all for that discussion. Let's go on to the biopsy. So we got one core that I'm showing at low power, and I'm trying a range of different annotation questions, and we'll see what works well for you. But let's start. I'm going to have you start with a basic question. Let's stamp where the cortex is and try doing the check mark for the cortex, and if you can put a little X where the medulla is. All right, so that's great. I'm seeing a lot of check marks on the left-hand side where the cortex is, and that's right. We have medulla over here on the right. Okay, so as Dr. Najafian said, sometimes we can learn some useful things from the medulla, but in this case, we're going to spend all our time on the cortex, which I'm showing here. And at low power, we like to get a sense of how much chronic injury there is. So I'll remind you what a well-preserved tubule looks like and what an area with tubular atrophy and interstitial fibrosis looks like. And I'll ask you to estimate how much chronic injury do you see here? Okay, I see pretty unanimous vote for moderate, which I agree. We called it kind of mild to moderate-ish, and I think we hesitated just because we don't have all that much cortex to look at in this biopsy, and so a little bit of question of how representative of a sample this is. But yeah, I agree. It's close to or a little bit over 25% of the cortex. Okay, so now we're going to look closer at the glomeruli. Here I am showing 3 glomeruli from this biopsy and 1 normal glomerulus as a comparison. So I'm going to see if you can identify which of these is the normal glomerulus. And then as an extra question, if you could find the very abnormal glomerulus. So yes, you'll find out this is the normal glomerulus. There were no normal glomeruli in this biopsy. And the most abnormal glomerulus is maybe not the most precise of questions, but I agree that this glomerulus looks particularly abnormal. Okay, so we'll take a closer look at this glomerulus and try to understand what's gone wrong here. So I'll see if you can find, to orient ourselves, a capillary loop in this glomerulus. Yeah, so we see, at least a couple here. And this one probably as well. And then see if you can find a mesangial region. And yeah, that one's a lot trickier. And this was a bit of a trick question because the mesangium's kind of blown apart. So we have mesangiolisis in this glomerulus, and we're really not seeing a nice normal mesangium here. And you did correctly point out a few capillary loops, but the capillary loops are also mostly not recognizable in this glomerulus. And so that's the result that, as a result of mesangiolisis, we're losing the structures that are holding the capillary loops in place. So when we see mesangiolisis, that could be the result of mesangial injury directly, or it can be the downstream consequence of endothelial injury. So to sort those out, I've circled a few clues here, these little pink blobs, and we'll see, what do you think these pink blobs are? Are they immune complexes? Are they fibrin? Are they red blood cell fragments? Or are they eosinophils? All right, and I see a lot of votes for red blood cell fragments, which is correct. So these are fragmented red blood cells, but they're it's hard to tell where they are, but they're not inside the capillary loops. So what this glomerulus has shown us are extravasated red blood cell fragments and mesangiolisis. And putting these findings together, and this is diagnostic of thrombotic microangiopathy. So as I mentioned, the mesangiolisis on its own is a pretty strong clue, but not entirely specific for TMA, but having those extravasated red blood cell fragments kind of steals the deal. It makes this a diagnostic of TMA. So there were a couple glomeruli that had these features, and then a few other glomeruli looked like this that are not entirely normal, and they're showing some ischemic changes. So when we say a glomerulus looks ischemic, we're referring partly to the what we describe as periglomerular fibrosis. So there's kind of thickening and fraying of the matrix around Bowman's capsule, and then the glomerular basement membranes get corrugated or wrinkled. All right, so we're going to move on from the glomeruli for now and start looking at the other compartments. So here we're looking at a few different regions of this biopsy, the tubules and interstitium, and see if you can put some annotations where you see an abnormality in either of these images. And yeah, that is right. So it's pretty much everything in this lower right image. And so I'll blow that up or actually let me go back for a second. So this upper left is a little bit closer to normal. And so normally these tubules are nearly back to back, whereas in this lower right image, they're spaced apart. And what's spacing these tubules apart is a lot of these inflammatory cells, as well as some pale areas which are representing edema. So we have interstitial edema and inflammation. And then we also have tubulitis, similar to what we saw in the last biopsy, but quite a bit more pronounced in this area. Okay, so we have tubulitis and interstitial edema and inflammation. All right, and then we're going to go to the vessels. And I'm showing just one arterial vessel here. And so I'll orient you that this is the media here with the smooth muscle. And then all of this so there's a small sliver of lumen, and this is all intima, which is a lot thicker than it should be. Normally the intima would be a single flat layer of endothelium. So a few observations in this vessel. One is that these endothelial cells are swollen, so they're a lot plumper, and they're extending into the lumen further than they should. And that's an indicator that the endothelial cells are injured or in some way, but not particularly specific or diagnostic. But we also see these pale areas in the intima, which we describe as mucoid change. And this is a feature of thrombotic microangiopathy as well. So there's some leakiness in this vessel, there's edema in the intima, and that's more specific evidence that there's endothelial injury and TMA. Okay, so I'll summarize what we've seen by light microscopy. We saw evidence of TMA and some glomeruli, and then we also saw evidence of ischemic changes, which are potentially downstream of TMA in the vessels. We saw a tubulointerstitial nephritis, and then we saw TMA in one extraglomerular vessel as well. Immunofluorescence was negative, so I'm going to skip over that, and we're going to look at some electron microscopy. And before I get to the EM from this case, I'm just going to give you a reminder of how to orient yourself in the glomerulus. So we start by finding these capillary lumina. And if these are the lumens, then we go on the other side of the capillary wall, and that's the urinary space here and over here. And then lining the wall of these capillaries, there's endothelium lining the inside of the capillary lumen. There's podocytes on the outside with their foot processes, and then in between this gray stripe is the basement membrane. And then holding these capillary loops together is mesangium. Okay, so now I've put that normal image here on the left, and then the right is an example of a capillary loop from our case. And I'll see if you will play spot the difference, if you can just put an annotation on what looks different about this image on the right, or where do you see the abnormality? Yeah, so I see lots of annotations here in this space that should not really be there. That is, all these annotations are correct. And also check mark on this podocyte, which is true, at least in this little portion, those foot processes are gone. But I will, so I'll remind you of the orientation. Forgive the bad tracing, but here's the capillary lumen, here's the endothelium. Here on the outside are the podocytes. There's this gray stripe of basement membrane, and then there's all of this space in between the endothelium and the basement membrane. So we have a very markedly expanded subendothelial space. Most of what's expanding this space is this pale or electron-lucent material, which probably represents just like fluid and plasma proteins, which is why it's a little bit grainy. But we also have a few cell processes and probably a red blood cell fragment here that are extending into this space. And so the subendothelial expansion is a hallmark of having endothelial injury, such as in TMA. And I just have one more example EM image, which is showing this same thing. So we have the capillary lumen over here on the lower right side of the image. We can identify the urinary space with the podocytes over here. And then here's this expanded subendothelial space between the endothelium and the basement membrane. And here we have some more clearly recognizable red blood cell fragments that have gotten out of the lumen and into this space. And so the EM findings are supportive of what we had already diagnosed by light microscopy of thrombotic microangiopathy. Okay, so I'll summarize what we found in this biopsy. We had TMA involving the glomeruli and one extraglomerular vessel. We had a tubular interstitial nephritis. I didn't show you the acute tubular injury, but it was present and probably secondary to these other processes. And then there was kind of mild to moderate chronic injury. So I think the question would often be what's causing the TMA and what's causing the tubular interstitial nephritis. And ultimately, we can't really tell by biopsy. So TMA for sure we'll discuss a little bit more later. But on a biopsy, we really can't tell what the underlying etiology is of the TMA. But lots of potential culprits in this patient with a bone marrow transplant. The tubular interstitial nephritis, again, wide range of possibilities. It could be drug-related. It could be related to an infection, including the potential of a viral infection with the immunocompromised state. Although we did an SV40 immunohistochemistry that I didn't show, which was negative. And then also the potential for graft versus host disease. Okay, so I am short on time, but I'm just going to briefly show you a few other examples from other cases, most of which came from this online resource that was had really nice images of TMA, because we had some good findings, but not all of the findings in this biopsy. So if you find fibrin occluding a vessel, that's essentially diagnostic of TMA, but we aren't always fortunate enough to find a clear-cut example. I showed you the mesangiolisis and the extravasated red blood cell fragments. And then you can also see swelling of endothelial cells that would include the lumina and TMA. And these are all more acute findings. When it's more chronic, you can see duplication of the glomerular basement membranes. And you can also start seeing scars form in glomeruli. And then in extraglomerular vessels, you see similar findings. You can see fibrin occluding the vessel. You can find endothelial swelling. You can find red blood cell fragments in the acute phase. And then when this is more chronic, you get this onion skinning appearance. Okay, and then the last few slides I'll just breeze over and we can talk more if anyone has questions. But as we've discussed for both of these cases, quite a wide differential for a kidney injury after a stem cell transplant, which where TMA is featured heavily in this differential, but many other potential causes, pre-renal causes, there's drugs, there's infections, et cetera. And then even within TMA has a really wide range of possible etiologies, and bone marrow transplant recipients have many reasons to potentially get TMA, including the alloimmune response with graft versus host disease. There's the medications, and particularly calcineurin inhibitors. There's often radiation as part of their the initial bone marrow transplant, and then they're prone to infection, some of which can be associated with TMA. Okay, so I will stop there. We're a couple minutes past 9:30, and if anyone has any questions or comments, please feel free. Thank you all.